We have a discussion session all about the reality of genomics data and its sort of enablement in the real world today. So we have three speakers from different parts of the world. So why don't you come up to the podium? So we're going to start this discussion session by each of our discussants introducing themselves and saying a little bit about their experience of working with genomic data exchange and its strengths and weaknesses to date. That is sort of where it's been a success and where it's been a frustration. But while they're talking, you've obviously got to listen to them, but I want you to be thinking yourself about what would, for your own life, be really enabling in terms of the ability to access data? What would make your life give it a step change in improvement? And also think a bit about some of the frustrations and the difficulties you've had in getting access to data and what you see are some points that are solvable or points that are fundamentally going to be extremely hard to crack and will really need international collaboration to do so. So I'm not going to introduce these people, they're going to introduce themselves, and as they introduce themselves, I want each of them to give an example of how data exchange and data sharing has been a really powerful force in the research and the programs that they've been trying to prosecute.
So I'm Tim Hubbard, I'm Head of Molecular Medicine and Genetics at King's College, and I'm also part-time at the 100,000 Genomes project at Genomics England. Is that not loud enough? I thought I was near enough the microphone. And of course before that I was at the Sanger Institute for many years working on the Human Genome Project. And so an example of good data sharing, which has really worked, has been the Human Genome Project 15 years ago. Of course at that time it was debatable whether it was going to be public, whether there's just going to be a private version. The fact that it was public, there have been lots of reports on the impact of that in terms of healthcare, and going on with things like the ENCODE project, which similarly operated, once you did the human, lots of projects following on have operated open data models. Now, of course, more recently, in the health service context, now you have genomes from individuals who are being treated, and it's a very different world. And so Genomics England compromise for that is you're not going to be able to take the data away, you're going to have to come and work inside our secure environment, and then it becomes challenging about how to do data sharing. But we're hoping that that will turn out, it'll be easier to do research in that environment than the current process, sort of halfway house of dbGaP and EGA, where you have to get permission one by one for each piece of the data using different access control committees, which can be a very, very slow process. So Genomics England will be a one-stop shop for things in the health system.
My name is Jean-Baptiste Cazier. I'm currently Chair of Mathematics and Director of the Center of Computational Biology in Birmingham. I'm originally trained as a mathematical modeler. I traveled the world a little bit before coming into this field, and along the way I've experienced different kind of data sharing. And I moved into the field. There are two examples I would like to give rather than one, if I can. And so I moved into the field of genetics about 15 years ago. I moved to Iceland with the Decode Genetics project. There the data is not publicly shared, but there was a shared effort across the country, and all the data has been available clinically and genotypically at the time. We are very proud to have the 1,200 markers to cover the genome, so it was a different beast. But so that was working very well to make a lot of research, and more recently, after working here in the UK and the Wellcome Trust in Oxford before Birmingham, I was a lot involved in the WGS 500 project, which is the whole genome sequencing for the equivalent of 500 people, pretty much. One of the ancestors of the 100,000 genome project, you can say, looking for clinical application. And it was, I believe, extremely successful in terms of research, because, again, it was not made public, but because it was shared and centrally organized. All the data was in one place, and we could, as well because of its size, we could talk to every single person involved, whether the genomics or clinicians, and everybody could be involved. That's what made it work.
My name is Satu Nakkuri. I'm from Roche Innovation Center Basel. I'm a data scientist there, working almost exclusively on preclinical data. I would like to second the opinions of Jean-Baptiste and Tim in that whenever you can have a one-stop shop to have all the data under the same umbrella, that makes a really huge difference in how useful it is for research, may that be industrial research for drug development or public research for understanding disease. And I think that one particular thing which we are currently very much excited about is the prospect of having phenotypic data, clinical data as it's also called, made such that it is commensurate across a large number of patients. It is very essential, for example, in cancer research, if the patient's tumors and treatments and responses are described in a commensurate fashion, because that is the way to really make sense out of the genomics data. Genomics data alone doesn't really help you much. Having nothing but the genomes is like having a phone book with nothing but the numbers in it.
Can you say a little bit more about how you're getting the clinical data, and as a commercial organization, how you sort of develop the trust that enables the clinicians, the patients, and the commercial side to sort of come together to answer a particular problem?
I'm at the receiving end, so I'm at the preclinical part. Yes. So regrettably, I'm not well equipped to answer that question. I don't know that much about the negotiations to go through. I can imagine there's plenty of jumping through the hoops to make it work.
Yes.
I can say about Genomics England, everything in Genomics England is consented. It's people in the health system who then are asked if they want to consent if they haven't got a diagnosis in the existing structure. And I think one of the structures around that consent is it's for treatment and research, and it's not based on redistribution. So people are not, they're signing up to making their data available for research, but that doesn't involve not knowing where it's gone to, relying on anonymization. It's anonymized, but it's in an environment where you know where it is. And I think that various surveys have shown that public feel much more happy with that sort of arrangement than it being distributed and not knowing who's using it or what is being worked on. So that's part of the design of that consent structure.
Okay, Jean-Baptiste?
I would like to add to that. In the example I gave, one of the main reasons it did work is because of the trust of the patient, and because I personally, a mathematician, didn't talk to the patient. Everything is done through their GP or their clinicians. We don't know anything about the patient themselves, we don't know their name, anything. They are engaging with their clinicians, with their GPs, with the person they know and they trust. And that's the way they convey the information. So our work is to make sure the clinicians are on board and understand what we want to do and the limit of what we want to do as well. And the trust lies at that level, and we rely on them.
I think the scary thing for me, and what all of you have described, is that your ideal is that there is a single place that's highly trusted where all the data is plonked, and then people can come and sort of work in that space and sort of do good things, and then take the results out. That seems to be very different from the sort of world view that we're kind of looking towards, where the data is all over in different places and we send algorithms out to data, and it's a much more real-time sort of live view of data, where there isn't that sort of single trusted monolith that we all go to deposit our data in.
Well, I think that's, this is probably not an ideal. An ideal would be where you could distribute it, but this is a pragmatic solution when you're dealing with healthcare data, where there's privacy concerns and ethics. And that's where we are right now in terms of what public perceptions are happy with. and what we can arrange. And in terms of the difficulties of doing your algorithmic research, well, it has got a lot easier because we can attach computers to this data and allow you to run virtual machines on them. And a few years ago, of course, you really wanted to take the data to you because you've got your own private setup of pipelines. But now pipelines are much more portable. It's much more practical to do this structure than it was, say, 15 years ago when the genome was done first. So, the hope is that this shouldn't get in your way that much. The problem, of course, comes where you have lots of different environments with whole sets of data and you want to federate across them. That's going to be the challenging thing, and that's where the Global Alliance for Genomes and Health is probably, that's thinking about those kind of things where you have to deal across national boundaries.
Yeah. Satu, you wanted to come back.
Yeah, so I don't think that we can, or we should establish monolithic systems necessarily. So what we need to do is make data commensurate, make it possible for us to run the same analyses in different places. We need to define and apply rigorously standards that make the definition of the disease and the characteristics of the patients such that we can compare apples to apples and really proceed with the research.
That's a great question. Great point. I think, so this issue of standards is clearly really at the heart of the ability to sort of have a more distributed view of how data is going to be accessible. Could each of you give an example, I think, of where you've struggled to make data from different sources either work or where you've invested a lot of effort in sort of getting data from different places and then it actually wasn't worth it, or you couldn't get the signal out. So some of the frustrations and difficulties of accessing data. Tim, you first.
So from the Genome England perspective again, genomes is the easy bit. The hard bit is the clinical data. And you're talking about a range of different diseases, and you'd like to capture relevant clinical data for that. Now, if you look at the way that data is not collected or collected in different electronic health record systems, it's really difficult. Even if you could get it out, it being in a standardized form. So the Genomics England approach is to write a data model for each of these diseases, and that's part of the NHS contract, that each of the clinicians will collect data to populate that model. And so in some ways defining, because clinical pathways are not standardized across the NHS, even just within the UK, standardizing what data is relevant for different diseases and subtypes, I think is a very, if you look at the precision medicine agenda, describing disease in this sort of terms it's going to be a very useful thing for standardization, so that you can then do analytics in terms of what the underpinning variation is, if you've got that standardized clinical collection.
Yeah.
I'd just like to second all this with a practical example, the WGS 500. When we are finding something, for example, in our cohort, which are all Oxford-based pretty much, we try to validate and use other centers to validate the frequency or whatever we found was real. One example is just one, would be TCGA, natural place to go, and we are going to see the variant we found has been found there. So that's very
Sorry,
good.
Jean-Baptiste, I'm not sure everyone will know
TCGA,
what TCGA is.
The Cancer Genome Atlas, a big effort to gather a lot of information about cancer data, mainly genomics, but not only. So, and as Tim said, genomics is the easy bit. So we can check the mutations, if it's there or not, the frequency. However, how does this mutation or the patient we're looking in that database relate to our cohort? How phenotypically similar is it? Is it the same disease? Is it the same people? Do they have the same diet, same ethnicity? We don't have that information, it's incomplete. So it's both a frustration and big hope, because it helps a lot to go that far, but it doesn't go far enough. And if you have a lot of things across the world, you need to have standards to be able to exchange, to understand phenotypically and know the limits of the applications.
If you'd had the Beacon project accessible at the time, the project that Nicholas was talking about before lunch, do you think that would have made a big difference to you?
Theoretically, yes, but there are always devils in the details. That's always where we are going at. The definition of disease, the definition of everything is between just clinically will be different, but as well there's often a difference in the cancer. For example, cancer in African ethnicity or Caucasian can be different, and if you design it in one way, you won't design it in that population. You don't know what you're going to look for. So there's a limit. It helps. But we have to look, personalized medicine, every single person is different. And there's so many parameters that make us. We can't collect all of them.
Satu, did you want to add?
I fully agree that the not typical clinical data, the quality of it is the biggest challenge. But I would say that there are still challenges in the genomics part as well. The sheer size of genomics files, the raw data files in particular, is so prohibitive that despite products as excellent as Aspera, it is always a bit of a struggle to move really large data sets, especially transcontinentally. And I think that, well, much of the time, making this transfer might not be the right thing to do at all. Instead, public data should be in the cloud, shared there, something like Elixir is probably trying to do. Private data sets should be in dedicated data centers, something like Genomics England, perhaps, where there's an access-controlled access. And the final point is to make is that in both of these cases, the data really should not travel to compute, but compute should travel to data.
Yeah. Okay. I want to open it. I want to open it up to the floor. Now, who has a sort of a vision of what the ideal world of genetic and genomic data exchange looks like, and some of the sort of concrete things that we can do to get there, or has an experience of frustration that they want to share? Whilst you're thinking about that, actually, I want to do a trial to get you thinking. So we've got three people up here, and they represent, if you like, healthcare providers, the NHS, academia in the middle, and commercial organisations on the far side. Who would you trust the most with your data? Hands up for the NHS. Hands up for academia. Hands up for the commercial world. So that's interesting. So about the same as academia, commercial, and NHS just about wins, but with a groan, I think. So your experiences, I'd love to hear from you.
Hi, I'm Michelle Krishnan. I'm a research fellow at King's College. My question is, how can we ensure that we take appropriate consent from the patients that we work with, given that sometimes the technology that's available to us and the questions that we wish to ask evolve very quickly? And I work with neonates, and we've collected data from these babies. Well, we've collected saliva from them years ago at a time where we didn't know what we would actually be doing. We knew we were going to analyze it, but we couldn't tell patients at that time, this is exactly what we're going to do. And how can we ensure that we maintain the trust that people have in us?
Tim, I think you should start there. So I think the strategy for that is probably to try and get a broad consent with these. So if you look at the Genomics England consent, it's on the website. It's a 150-page document for the REC approval. It basically says this is for research and, of course, clinical treatment. So if there's benefit to you as an individual, that will be fed back. But it defines the kind of areas which are classed as acceptable research activities and what are not acceptable. And that's the kind of guiding principles, rather than very narrowly saying you're going to use it for X. Because we think that's going to produce the most benefit. I mean, in some ways that's compromising the other way. Rather than having very narrow consents, try and make them as broad as possible. And I think that's the same structure that's been adopted by the biomedical research centres with their consents when they operate biobanks, is to also try and have a broad consent. One of the problems at the moment, I think, in the NHS and the associated research clinical enterprises, these consents are not entirely totally compatible. If we had a universal consent across the NHS and the research space, this would make things a lot easier. And I think if you marry that with the non-distribution model, then I think people will probably be happy with that. And people being consented in hospitals, I know examples from Switzerland where you are asked as you come through the door even, do you want to give a sample for kind of generic research that may benefit you as well? 75% say yes.
I'd be interested to hear whether you think that would work, would have worked in your case. If you'd said to the people, we want to enroll you in a study with an extremely broad and somewhat vague research consent, how many do you think would have signed up?
Well, that is effectively what we've done, really. And I've been involved in designing consent forms for ongoing studies that we have, and we try to design them based on principles, so that when we talk to people, we're discussing the intention behind what we're doing, rather than the technical specifics, which are often actually less relevant to people. And given that we're consenting the parents of babies that are sometimes not yet born or that have just been born under very stressful circumstances, our acceptance rate for the genomics part, and we also do MR imaging of the baby's brains, is extremely high. It's 99%, thereabouts. So people are really, really engaged with involving their newborn, very fragile babies in this type of research.
That's an amazing story. Yes, in front.
So I guess I've seen similar experiences in Europe, but when you move to a healthcare system that is very much insurance-based, and I'm thinking particularly the United States here, we tend to see very, very different consent forms. And we have a number of challenges with data that we've gathered, where we have data that is consented, say, purely for, say, COPD research, and you're not allowed to use it for asthma, or you're not allowed to use it for other things. Now that's great in terms of the immediate clinical trial that you're running, but in terms of the ability to get extra information and so on from that data, it makes it very, very difficult when you bring all that information together and there's set people in the company who can see it and there's set diseases you can search for. So the integration challenge then is an immense legal one as well as a practical one.
So maybe that's a good reason for doing research in the UK.
So, any other frustrations or things that you think we should be thinking about? Yes, there's one just by.
Hi, I'm interested in deep phenotyping. And,
can you introduce yourself?
Sorry, my name is Dana Kenny. I'm a clinical geneticist at Great Ormond Street and a researcher at the Institute of Child Health. And I'm interested in deep phenotyping in rare diseases. So, why do some patients get kidney cysts in a specific disease, some get extra fingers, some get none of those things? And one of the frustrations is recording the phenotype data. Both, how it was collected originally and the variability among clinicians and so on, but also how you actually record that data to make it usable with your omics data. And it's something that I don't feel, I feel like I'm kind of having to reinvent the wheel.
Yes.
And with cohorts of multiple rare diseases, how you find a one-size-fits-all solution, can you?
Great question. Tim, you may be at the right place to start there, but actually after Tim's spoken, I want other people who've had the same problem in the audience to think about their solutions, because I'm sure that's something that a lot of people here have come across.
So as I said before, that this is just a generic problem with what's collected as part of clinical care versus what you'd like to have for research studies, and that the Genomics England Clinical Interpretation Partnership, which is the research arm, the hope is that will have both clinicians and researchers, and that is already happening with the design of these data models. What's the right balance between collecting data that's going to be useful for research as part of clinical care versus what the researchers would really like, which is probably more than clinicians want to collect. And then, of course, the model has recontacting, so if you really want to do some deep phenotyping, you can always try and approach the patients afterwards to do some more work. But I think the biggest problem is about the standardized data collection, and we're working on that, but it's an NHS-wide problem. 100,000 is just a narrow slice of all patients.
So
A lot of this is about secondary care data systems and standardization.
So I'm interested to know whether you're aware of the activity that's going on in the Genomics England, and I mean, do you feel that
it's actually not just GEL, it's also the HIC, the Health Informatics Collaborative, which is also trying to standardize models around certain areas.
So that's a way in which, in theory, the kind of work that you're doing shouldn't be reinvented elsewhere, but
I suppose it's difficult because we do recruit patients to GEL, and that's fantastic. But I suppose we have a lot of historical cohorts, and the problem with rare diseases is that you collect your patients over a long time, and so you have the data that you have, and it's around recording and integrating the data, and I think you guys are doing a fantastic job, but we can't submit all of our historical patients to you. I wish we could, but it's how we work with what we have, really.
Yes, okay. Some of this is actually just making it easier for clinicians to enter data, because existing EHRs interfaces are really difficult for them to use, and so there's a lot of gaps in the data rather than just standards problems.
so who else has either struggled with or found good solutions to the sort of phenotyping problem in this room? Who's got something they think they can share as a solution? I think I'm going to have to ask our panel members to solve the problem then.
Actually, is pointing out to Tim is the fact what GEL is trying to do, among many other things, is to create community, and those standards should not be across all the diseases. They should be made within a community, force, in a sense, people to talk to each other, because you are the expert in your field. Talk to each other and see what is relevant. And those are the standards you will set for you, for your group. Yes, in the future you may have to change slightly, but everybody who knows, all the experts should be talking with each other. And that's what is a side effect, but I think the main effect of the GEL project is to make sure those things are happening. And that's, I believe, the way to go is standards, but personalized standardization.
Sasha, is there?
So basically, Roche is also a member at the Gene Consortium, which is the genetics genomics experts network for in the enterprises which is in the scope of Genomics England. And from our point of view, it would be a really wonderful outcome of the project if it would define a model for both cancer and rare diseases that is unified and comprehensive, because that might be, if good enough, be something that's even adopted just outside the UK. So, fingers crossed.
Okay, I think on that optimistic note, or at least spur to Genomics England to solve all the world's problems, then we shall thank our three discussants again.